Can everyone see the PowerPoint?
Yes, we can see it, Professor.
Great. Awesome. All right. So this workshop, the reason I put this workshop together is because I want you guys to understand that sometimes it's not about knowing what's right in pediatrics. In pediatrics, the biggest thing is not having harm. All right. So when we're dealing with these tips and tricks with pediatrics, you're always going to look for the least incorrect answer. The first thing you're going to do is you're going to always look at your choices and see what you can eliminate first. All right. Try to get rid of your options because it's much easier to guess from 3 options than it is from 4. And it's much easier to guess from 2 options than it is from 4. All right. So always try to remove answers. All right. And then know what not to do. All right. Very important part of this dealing with pediatric questions is knowing what not to do. What doesn't prioritize the patient's autonomy or the parent's autonomy. You want to maximize choices in pediatrics. You want to be that kind of, remember that whole family-centered care model, this idea of being warm and welcoming and always kind of doing things that aren't going to hurt or scar anybody. All right. Always keep in mind the age group. If an age group is given on a child, that age group is important. At some point, it's important. It's going to come up again. All right. Focuses on differences and rather on similarities. We've talked about a lot of disorders in pediatrics. In pediatrics, there's so many disorders that sound really, really similar. The biggest thing is to know what the differences are between those disorders rather than trying to memorize that each one has this specific prognosis. So knowing that all the respiratory conditions, okay, the priority is going to be airway, but the difference is sometimes whether the airway is lower respiratory that we're dealing with or an upper respiratory because it changes the way we approach answers. All right. And Erickson stages of development will help you when you don't know what to do because so much of the psychosocial part of pediatrics is dealing with those stages of development. All right. Planning education, any kind of interventions that you're going to do, and priorities at discharge all play into stages of development. What is appropriate for this child, for this family at this point in their lives? Those are all things that we have to think about when we're approaching a question in pediatrics. All right, so here's a nice summary chart of these stages in pediatrics. And I like this chart because what it says on the right side is that this idea of an outcome, right? And these questions that these children are trying to answer at each stage. So at each age, we have a question we're trying to answer for these kids, right? So in infancy, all these kids want to know is my world safe, right? So it's all about making sure that these children are safe. So going out into the world and making it safe, making sure that their parents are making the world safe for them, all right? Preschool age, when we're doing any kind of intervention as far as behavioral or anything like that, kids need to know whether they're being good or they're being bad. So establishing them right up front, because at that age, all they care about is getting attention. They don't care if they're good or bad. They just care about getting the attention. So if you're giving a child that's preschool aged constant negative attention, well, that's what they're going to do because the only way they get attention is if they do something bad, right? So the child thinks that they're inherently bad. So they continue to make bad choices because it's the only time they get that behavioral challenge. All right. So now the other thing that we have to worry about is when we get to this school age, they want to do everything possible to be good, right? School age is when they get to school and they decide, hey, I want to be good. I want to be the best, right? I want to do this. They're very, very much about pleasing people around them. So they always want to be very, very involved, very, very heads-on. They're into their social demands, right? They want to be with everybody, right? And that's really important to remember when we're dealing with these guys, all right? That you have to keep in mind what's their key question that they're trying to answer at their psychological stage. And that's going to help you guide what you're going to do and how you're going to respond to these children. Because no matter what they're saying, the core of the answer is, what are they trying to do now, right? What's the truth of it? So let's look at how this plays into a question. So the nurse is completing an admission assessment on a 10-year-old girl being admitted to the hospital for EEG monitoring. The mother explained she adopted her daughter 8 years ago, and although she is developing normally, there are some lasting effects of her daughter's severe neglect as an infant. Which nursing interventions will be most therapeutic for this child? All right, now it's given us a lot of information here. What can you guys pull from the STEM that you think is important for this question? Which age groups are we given? Because we're given 2 age groups. Come on, guys, you have to talk. Karina, what do you think is the most important thing about this stem of the question? What is it asking you?
I don't know, I'm trying to figure it out.
Okay, don't try to figure it out. Just look at the stem of the question. What age groups are we given?
She's 10 years old, so like school age.
She's school age. And what else do we have?
Could it be that she was adopted 8 years ago, so she has the severe neglect as an infant?
Yeah, so you've got infancy and you've got a 10-year-old. Now, where did we have a crisis in this child's life? Where could we have a potential that this kid didn't meet a psychosocial stage? Is it now as a 10-year-old or is it as an infant?
As an infant.
All right, so what's the priority in infancy? What do we got to do? We have to develop what?
Like safe, like making sure.
Trust and mistrust?
Yeah.
Yeah, we're about trust and mistrust. So the nursing interventions that are going to be therapeutic for this child have to deal with trust and mistrust. Is extra trips to the treasure box going to give us trust or mistrust?
No.
No.
No, it's not going to work for this. What about sticking to a schedule and getting a schedule and sticking to it? Is that going to develop trust?
No.
You don't think sticking to a schedule? And
It may
it
because
might.
she knows what's
Yeah.
coming.
Yeah, she knows what's coming, right? Her world is safe. She
Okay.
knows what's coming. It's about that idea of planning. So that can develop trust. What about encouraging the mother to take the child to the playroom so they become more social? Did we have a social concern with this child?
I don't think so, no.
No, so that's not really going towards that whole therapeutic part of that trust versus mistrust. What about explaining procedures to a child in detail so they understand what's going to happen? Is that playing to trust or mistrust?
Yeah.
Yeah, gets trust going. All right, rewarding the child with vigorous verbal praise for good behavior. Is that about trust?
I want to say yes.
Is it? Is it more appropriate to which age group though?
Um,
Who's concerned about
Like
good behavior?
I think preschool or no?
That's more of our preschool
Yeah.
kids, right? They need that vigorous verbal praise that they did the right thing, right? They need to know that they're good. What about this? Allow the child to choose which parts of the treatment plan they participate in.
Yeah, trust.
It is about trust, but is this realistic? Is this something we can do for a child in this age group?
No.
Maybe not.
No, it's not something that's safe, right? So even though it applies to that whole trust principle, it's not safe. It's not something we want. So I think what we've ended up with is we've ended up with these same ideas that we want to use that schedule and we want to use that detail. So those procedures in detail, those daily activities, the key about this is trust. All right. The key to this question was figuring out which ones make me encourage trust and which ones are things that I can actually do. I can give a schedule of activities and try to stick to it. I can give a kid a lot of detail about procedures, but I can't let them pick and choose their treatment plan. All right. So that's part of it, is that really that kind of looking at everything all together, not hyper focusing on one thing, but kind of realizing, okay, what is this question actually asking me? It's asking me about which ones would encourage trust. Right. So again, that developing normally was about doing well. This kid was doing well academically and socially. And this lasting effect of this infant not reaching this Erickson stage is that trust versus mistrust. So really, when you're looking at these answers, you're going to say, which ones are making the child know that this world is safe? All right. And it's every very one we went through yes and no. Is this going to make it safe? Is this trustworthy? Yes or no? And remember that with select all applies that each answer is independent. We don't have to choose certain ones. All right. And usually with select all that apply, the options are either 2 or 3. All right. There's never usually with the select all apply that it's 1. All right. And most of the time, select all applies usually have 2 or 3 right answers. All right. So always keep that in mind when you're looking at these. All right. So that first one, that extra trip to the treasure box, has to do with am I good? That's a preschool age. All right. We also want to be careful with this because we can use this as sympathy for abuse. That's not very therapeutic to be sympathetic that she's got abuse, right? Empathy is what we game for, not sympathy. All right. And that same idea that reduces surprises, right? We said B was good because it reduces surprises. It makes us keep to a set schedule. It encourages that trust to develop. C, when we're looking at C, how can I be good? That's school age, but it's social hasn't really been brought up as the mother as a concern for this kid. Right. And again, that explaining procedures about reducing surprises and explaining in advance. It encourages that trust to happen. And in E, what we're looking at is how can I be good? That's again, that school age is not part of this concern for this parent, but this is also that can be that preschool age, which am I good or am I bad? Right. So it's not appropriate for this kid when we're really looking at that trust is what we're trying to build. Right. All right. And then again, on the bottom part, this kid does not have decision-making authority. This kid is here for a procedure. All right. And it also plays into that early childhood. Can I do things for myself? All right. Which is not what we're trying to answer with this question. When we're looking at questions, a lot of questions, we have to roll back to that 222 stuff of primary prevention. Primary prevention is all about what are kids at risk for? What kind of trouble do they get into? All right. And oftentimes these things that they get into are things that we can prevent. All right. Things that we can teach and educate. So a lot of education builds into primary prevention. And that's true across the line. We have to educate about things like sun damage, accidents. All right. What are preventable versus self-inflicted, right? Things that they do to themselves, right? Climbing up on a shelf and pulling it down on themselves, right? Things like obesity, they don't eat very well. Remember that whole idea of physiological anorexia, especially in toddlerhood. They don't get enough exercise sometimes at many, many different ages. All right, not sleeping well, staying up all night and playing on their phones and not having the energy to go to school or make good decisions. All right, when we're talking about illness, we're talking about vaccines versus hygiene. For each age group, what vaccines are important and which hygiene practices are important, right? When we're talking about babies, the hygiene practices are focused on the parents, right? We can't depend on a baby to wash their hands, but we can get the parents involved in making sure that we're not getting things from their bottom to their mouth, right? That they're not sucking on dirty rags or whatever, right? That they're in an environment that's clean. So that idea of hygiene versus vaccines, which category does illness happen on? So we need to make sure that we've got that both comprehensive care when we're dealing with prevention and what kids are at risk for, right? Same thing with abuse. We have to worry about those immersion injuries, especially like the drownings. All right, bruises at different healing stages. All right, those uncommon areas when we've got to worry about that abuse and that child abuse. All right, and again, any kind of circular patterns or scars. All right, what are they at risk for? Who's going to be likely to do these things to them or allow them to get into these situations where they happen? All right, in newborns and infants, again, it's this idea of things we do to them. All right. So we put them in the car seats. We don't put the car seat in properly. All right. We put them to sleep, right? They might suffocate. They might have things in their bed. They might choke on something. They may not be able to breathe. Things that happen are that maltreatment and harm. We've got to worry about shaken baby syndrome, right? So when we're looking at kind of primary prevention ideas, and it's asking which kind of primary prevention activities are we including in newborns and infants, we're looking at all of these areas. All right. As far as nutrition, we have to worry about those supplementations, that vitamin D, that iron, B12. If their family's a vegetarian and the mom's vegan and she's breastfeeding. All right. Remember that no cow's milk, no honey for the first year. And that has a lot to do with nutrition, but as well as infection prevention. Remember that idea of infant botulism. All right. And also that same idea of solid food that's appropriate around 6 months. All right. So if you've got something in a question somewhere that's saying to feed something to someone, and they're less than 6 months of age, you should say, is this right? Is this the right kind of thing to be feeding them? Because we do have some food that we do give to children under 6 months. Remember that rice cereal for reflux? That's really the only exception to that rule. Around 6 months is when we really start getting into a lot of different foods. And we want to start slow and we don't want to do everything all at once. All right, toddlers are usually things they get into. This is where we have to put parents on alert. This is what they get into. This is what they do. This is the behaviors they get into. So things like lead poisoning, like eating the paint chips off the wall or drinking your Clorox underneath your sink, right? Drowning, jumping into pools, going into the toilet bowl in the middle of the night, aspiration and choking on things. Those are very important things to remember that toddlers get into these things, right? Because they're more independent. They're feeding themselves. They're doing these things. But we have to watch to make sure they're not getting those things that can cause them to get sick. Little bits of little pieces of meat, steaks, and things like that are also things that they can choke on. And that same idea with motor vehicle accidents, these guys have a lot of retaliation to restrictive car seats. And parents trying to get them to be in the car seat are putting them in the wrong car seat or flipping them around so they face forward and they can watch the TV in the middle of the car. But if these kids are too small, they're not supposed to be like that. They do things just to kind of get their lives a little bit easier. But we have to understand that these guys get into trouble. They get into trouble very, very quickly, right? They're not designed to be watching over themselves, right? They have to be watched pretty much 24/7, right? Preschoolers, the things that happen to preschoolers always have to be about this idea of trying to be big kids, right? We're trying to be big kids. We want to be like our school age siblings. We want to be like our cousins. All right. So they're climbing, they're jumping on everything. They're getting into cabinets and drawers. Things like gun safety and fire safety start playing in when we get into preschool age. Again, with those drownings, right? Because they're getting into the pool. My brother swims by herself. I want to swim by myself too. All right. And also that idea of poisoning still too carries over until that preschool age. Because again, they're trying to be big. They want to be just like everybody else. If they can get themselves a drink, I can get myself a drink. All right. That idea of I'm trying to be a big kid. Right. School age children, remember the things that their friends get them into are usually what they get into. So if they're biking, if they're into sports, they're getting those sports injuries. All right. We're also talking about things like infections and childhood illnesses, things they get from their friends and they're contagious. All right. All those childhood illnesses that go rampant in schools and daycares. All right. Those are all the things that we get into when we get into school age children. They really, really get things from their friends. They're really involved in playing with each other. And that's a big, big problem. Right? Psychosocially, we're also looking now, we're starting to crop into the psychosocial. Before the school age, we really don't look at any psychosocial stuff. All right, we really don't look into that individual concern for psychosocial because it's so limited. It's things we've done to them. But now with the psychosocial age, they have their own peer relationships. All right, they identify with their own gender, boys or girls. Am I a boy? Am I a girl? Who am I going to hang out with today? This is this no boys club or no girls club. All right, and they start feeling that stress of academia or not fitting in with everyone else. That's what happens with school age children. They don't fit in. They want to be like everybody else. They want to please people. They want to please their teachers. They want to please their coaches. They want to please their parents. This is that nice age before they hit the teenage years. All right. This is a really nice, great age that we can do a lot of growth and development. And they start becoming independent. We're teaching them, right? We're teaching them what their friends can get them into that are problematic rather than worrying about the parents. Now we're going into the kid itself that we're educating. All right. Adolescents, really, really big idea behind them is that they're trying to stand out to fit in. All right. They want to stand out. They want to be different. All right. But they want to be different so that they look cooler than everyone else, not because they want to look different than everyone else. All right. So they're trying to be this cool kind of thing. And this is where we get into our very, very big with these accidents, with the motor vehicle accidents or this extreme sports, really experimenting and be like, okay, well, if she's a great horseback rider, I'm going to be a great bungee jumper. All right. Those are that same ideas. They want to be the best at something. All right, trying to be the best and on top. All right, that same idea with mental health. Now we've really gotten into this idea of mental health with adolescents, is that while we were touching on it before in that school age, really, really, really comes into play here because it's a lot of growth and development. How do I bridge that gap of being a small child to being a grown adult and making my own decisions? That's the big idea with adolescents. I want to be individual and independent, but I'm not quite ready yet. And don't ever let them hear you say that. All right, that idea that substance abuse, eating disorders, all these things that they can do, right? Sexual identity starts to become a big, big crisis here. Now it's not am I a boy or a girl, it's who am I attracted to? And there's a lot of experimentation that goes along with that. Do I want to kiss boys? Do I want to kiss girls? Right? Who do I want to hang out with? And that same idea that now that they're touching each other, this idea of sexually transmitted infections really, really comes into play. Remember those things that we have to report to the CDC, our chlamydia, our gonorrhea, our syphilis, those crankoroidoids, all those things that we have to report to make sure that we catch them, right? And remember that a lot of those same things, if we have them in a boy and not in a girl, they may be very, very asymptomatic. And that's the biggest reason that we have to report a lot of those sexually transmitted infections is if they have not a whole lot of external symptoms. All right. So a lot of those STTs that don't have external symptoms, those are the ones we have to report. Those are the ones we have to make them aware that they may not see that there's a virus or a bacteria on somebody else. All right. And that's the education we have to give them, that you may not be able to see that someone else is sick. That external sign of illness may not be there for them. All right. And that same idea of that teen pregnancy, right? They need to be prepared to prevent pregnancy. If they don't have the knowledge, They can't prevent the pregnancy from happening. All right, so let's do this one. So a mother brings her child in for a second dose of the MMR vaccine. After seeing the physician decides that the child should not receive the second dose. Which of the following are contraindications for the MMR vaccination? Take them one by one. So is immunosuppressive treatments, is that a contraindication? Can we take the MMR vaccine if we're under an immunosuppression treatment?
Yes.
No, right?
No, it's
Remember, it's a
not.
live vaccine. Remember, it's a live vaccine because the MMR is going to make us sick. All right, so MMR is going to make us sick, so we can't do that because we can't get those kids sick. So no for A. Yes, that's something that's a contraindication. What about reaction to previous MMR dose? Should they get another dose if they've had a reaction to it?
No.
No, they shouldn't get a dose. So we like that one too. What about current minor cold symptoms? Does that mean they can't have it? Vaccinate or don't vaccinate for current minor cold symptoms?
Vaccinate?
Vaccinate.
Yeah, let's vaccinate those guys. What about travel to a foreign country? Vaccinate or don't vaccinate?
Yeah, vaccinate.
Yeah, vaccinate. What about less than 4 weeks since the first dose of the MMR vaccine? Vaccinate or don't vaccinate?
No, it has to be a month, no?
No.
Yeah, they need to be longer away. Remember, it makes them sick. We can't have these kids kind of on that constant sickness. So the kids we wouldn't vaccinate, we don't have any immunosuppressants. All right, don't want any reactions from previous vaccines. All right, and then we want more than 4 weeks between doses. Remember that this idea that people may delay doses or get on a delayed scheduling of vaccinations, and that's becoming more and more popular as time goes on. So that idea of knowing how far apart those vaccines are, especially the MMR vaccine, and is very important because you need 2 doses, right? So any vaccine that's got 2 doses, take a peek at how far apart they have to be for those doses to be effective, because that's something that's going to be helpful as it goes forward, because it's something that kind of crops up here or there, but it's kind of like a surprise. Oh, I don't remember, but I know that they're supposed to get it here and here. But remember that there's some kids that are on that catch-up schedule. They don't always have that first dose when they're supposed to have it because the parent feels they had a lot of vaccines at once. So parents have that autonomy to move the times of their vaccines around, right? Which can make it very difficult sometimes when we're trying to avoid certain illnesses. All right, so a middle schooler fell off their bike at the park, went out with friends. When the parent picked up the child, they noticed an obvious bruise to the forehead, but no other signs of injury. The parent called the pediatrician to see if they should bring the child in for evaluation. Which symptom do you think would be the most concerning? All right, now these
The
are all
vomiting?
concerning symptoms. Huh?
Would it be the vomiting?
Headache?
Okay, now dizziness is nice, but we'd expect this kid to be dizzy, right? They hit their head. All right, so all of these are things that are not good, right? We can agree on that, and nothing's good here. But the worst one is that vomiting, all right? Because A, B, and C are all about this concussion. They're all abnormal. But D is that symptom of intracranial pressure, all right, that ICP. The rest of these are all ones that we kind of expect for a concussion. They got a little sensitivity to light and noise, a headache, dizziness. Okay, you hit your head. All right, but vomiting without nausea, that's that ICP, that's that intracranial pressure. Remember, none of these symptoms were supposed to be good symptoms. They're all things that something has happened, but one of them means something different than the others, right? The other ones are all marked parts of a bruise on the brain. This vomiting without nausea, we've got something else going on, something deeper. All right, secondary prevention. When we're dealing with kids, we have to think about this idea of how do we know when they're sick? How do we know if they're sick? How do we kind of determine there's something not quite right with this kid, right? And with each grade group, we have these kind of parameters that we have to look at, all right? So kids that have an extremity of noise, right? If a kid that's usually very, very loud gets very, very quiet, we know we've got a problem. All right. If a child that's usually very irritable or agitated is lethargic or withdrawn, with children, it's those extremes that say, something's not quite right. Right. If somebody's speaking very, very loudly, you go, they can't hear. Right. They can't hear what's going on with them. They don't think they're being heard. Right. And somebody that's very, very quiet is kind of in the corner, away from everything. All right. Kids are usually in the mix. They're in the middle and they're getting in trouble. All right. Signs that we have to look for. Things like fluid volume. Is it an excess or a deficit? All right. Do they have function? Are they consistently or inconsistently performing something? Right. When we were talking about like our muscular dystrophies and things like that, they used to be able to do that, but now they can't. That idea of not having consistency or being impaired, those are things we worry about when we talk about, are they not quite right? What means something's not quite right? Feeding. When they're feeding, if they're demanding, I got to eat every 2 minutes right now. All right. That feeding is very, very important because that idea is that they're starving. Something's going on with their cells that tells them that they're starving. Right. So kids, when they feel like they're starving, they're very cranky, very agitated, and they're going. Something's increasing their metabolism, or they're not absorbing nutrients the way that they're supposed to. All right. Or apathetic. They don't care to eat. Well, why would a kid not care to eat? All kinds of reasons. All right. Illness, cardiac abnormalities, kidney abnormalities, GI abnormalities. There's all kinds of reasons that a kid would not care to eat. So a kid not caring to eat, especially if it's consistent, has to make you go, So if you see a question on a test and it says, which one is most concerning? And you go, look for the ones that are extremes. Anything on the extreme side, either very, very loud, very, very quiet, or that irritable or agitated, or that lethargic or withdrawn. Those are all things that make you go, Things that are right down the middle. Kid sleeps pretty regularly. Kid does these things pretty regularly. Those are okay. So things that kind of sound mild mean they're okay. But when kids start hitting an extreme, either one way or the other, we got to start worrying about them. All right. When we're dealing with newborns, we still have this idea of the APGAR. All right. And this is something that does come up in pediatrics occasionally when we talk about this APGAR, because we have to talk about this idea that it's about blood flow and blood flow going through the body. Right. So when we're looking at the APGAR, we always have to have this idea that we've got this idea of the appearance. Does this baby look good? Is this baby nice and pink all over? Is their heart working? Is their lungs working? Because sometimes when you get a newborn question, it's going to give you an APGAR scar. Now, what's important to remember than APGAR score, the slower it is, the worse it is for that kid. All right. And the idea is that if you do a 1 minute and a 5 minute, you want that score to go up because a healthier baby has a higher score. All right. So that's always really important. Remember these APGAR scores. All right. Not so much the exact details of it, but this idea of why is it important? Okay. It tells us that this baby has got connection between their heart and their body and their brain and their body. Right. That connection between those pieces is very, very important. That all this kid criteria that this kid meets means that this kid is ready to live. All right. When we're dealing with newborns and infants up to 1 year, we have to keep in mind what the normal is for that age group, right? Normal physical changes, right? In that first year, they should be gaining 6 to 9 pounds. In the very, very beginning, in the first few days, they're going to drop their birth weight. So a kid is actually going to look smaller right after they're born in the first few days, but they should go back up over the following week. All right. So this kid that continues to be drop weight, you got to go, oh, something's not right. Why is this kid not metabolizing? Why are they continuing to lose weight 2-3 weeks out and they're not gone back to their birth weight? So that should be an alarming factor. All right. In that first year, we see a lot of increased height and weight. They should be growing and changing a lot. All right. Remember, we've got to keep in mind these same screenings, the PKU, the glastostemia, the hearing screening, right? Can this kid hear us? Does this kid have any organ abnormalities? Right? Either in development where they're congenital and they're born that way, or those organs just aren't functioning. They're not up and running yet. Like our liver. Our liver takes some time to kick in and work like it's supposed to. Our kidneys take some time to kick in and work like they're supposed to. That's why babies have such a high urine output and have such a high risk for dehydration. Right? So if we have a baby that's not putting out a bunch of urine, we have to go, that's abnormal. That kid needs to be putting out more urine. It's an infant. It's less than 1 year of age. Its kidneys aren't working great. All right. And at the same time, we have to worry about those cognitive and psychosocial changes. The only way a newborn before it has a way to communicate is crying. right? And so somebody not responding to that crying is interfering with that trust, right? If that's the only way you can communicate with the world and nobody's responding to you, that's going to cause some conflicts within that child, especially as they get older. All right, bonding is extremely important. Remember this first month of life idea. So we have to think about what these kids are stuck in the NICU for 1, 2, 3 months at a time, especially our preemies. They have a very limited environment. They don't get to spend all that extra quality time with parents. Could they have an attachment issue because they haven't been with people that whole time, right? They haven't had that experience of different things in the environment. Infants need to be exposed to different things in their environment. They can't just stay in that same bubble like a bubble boy all the time. If they don't see and experience things, they're not going to know these things, right? They have to have that first-hand experience. You can't tell them about it, right? Same idea too is very, very solitary play. Things that are funny to infants are things that are funny to them alone and not anybody else most of the time. All right. And a lot of that language is really crying, cooing, laughing. These are all that imitation of sounds that they get from the world around them. But again, if they're not exposed to those sounds and those languages, like when we think about like feral children and things like that, if they're not exposed to that crying, cooing, and laughing, they're not going to do those things. They're not going to know what they mean. They're not going to understand the facial expressions of another human, right? They'll have that inability because they haven't seen it firsthand. All right. Nice to keep in mind of these gross and fine motor delays and when we expect things to happen. All right. So where we see this birth at 3 months, we got to have this gross motor. If we see a delay, it's things like this baby cannot be sat upright, right? This baby isn't able to pick their head up and hold it. All right. Oftentimes where we have to look for alterations in these gross and fine motor skills is specifically in preemies. All right. Preemies are going to be behind the rest of the curve. Remember that they can be months behind the rest of their curve. All right. Remember, we can save babies as early as in the late 20 weeks. All right. And I know some 24 weekers and stuff out there. All right. They didn't have that much time to cook. They're undercooked children. They take a little bit longer to reach those developmental milestones. So your expectations of somebody that's a preemie is going to be much, much lower than a kid that's born at full term. All right. Kids that are chubby, especially kids that are chubby with gross motor, will be gross motor delayed. Kids that are little reach those gross motor skills much faster because little kids, it's easier to pick up 6 pounds than it is to pick up 10 pounds with your little legs. All right. That idea of being able to use those muscles and move those muscles. All right. Because it's a lot easier to pick up those. Again, standing up when you're only 6 pounds is much easier than standing up if you're 10 pounds, because it's that idea of being able to move your whole body. All right. Girls tend to always be faster than boys. Girls tend to be faster, moving faster. They tend to talk faster. They tend to be expressive faster. That's just the way of the world. Boys just need a little more time to catch up. So when we're dealing with girl babies, we have to know that, okay, they might go a little faster than everybody else. We got to make sure those boys don't lag behind too far. All right. First children always tend to be a little bit slower than those second and thirds, because remember, those second, thirds, fourth, fifth, sixth children, they watch all the other kids. And to be like the other kids, they start picking it up. They see how another kid does it. So they start moving a whole lot faster. All right. Oftentimes, if we have a kid that's behind, we need to start looking at ruling out neurological versus a musculoskeletal issue. Is that the kid wants to do it and just can't communicate to their muscles to do it? Or is there an issue where the kid is trying and trying and trying, but the muscles aren't able to do it, right? Is there a communication problem or a physical delay, right? If we're looking at a kid with like head lag and we're looking at something like torticollis, where they can't turn their head from side to side, so how can they possibly lift their head up to be straight up in the air? Right? Because they can't turn their head from side to side. Do we have a muscle weakness issue? Do we have a muscle that's really preventing them from doing the activity, even though everything says that they're trying? Toddlers, when we're looking at toddlers, big things we have to worry about toddlers, especially those physical changes, is that physiological anorexia. Remember, this is a big, big time of fine and gross motor development. They are growing and moving and making these milestones happen, all right? But they're not eating because they've already stuffed up on a bunch of food. All right, they stocked up on a bunch of food in their little infant years, so they're ready to go and to grow and move and really cruise on getting things together. All right, really starting to recognize themselves as a separate entity. All right, continuing to imitate the language of their parents. We're still looking at that more words, and you can see that word explosion from 18 months to 24 months. We're going from 10 words to 300 words. They are absorbing everything around them like a sponge. Completely sponging it all up. all right? Masters of their own body functions. They're trying to learn to be independent, to do everything by themselves. All about that temper tantrums, negativism. Remember, these guys are not the funnest to get along with, all right? They want what they want when they want it. All right? So it can be very, very tough dealing with these guys, all right? I want to be proud of myself. I want to be doing things, all right? But remember, they're not exactly the most social either. These tend to be more of a parallel play group. They're not really interacting or engaging with somebody else, all right? They don't really care what anybody else thinks. They're going to do what they're going to do. All right, and that comes back into that temper tantrums and that negativism. All right, screening is really, really focused on those neurological and musculoskeletal issues because, again, this is a huge area of fine and gross motor development. And as well as, too, we're looking at daycare illnesses. These kids start going to school and they're around other kids at school. Now, this tends to be more of a hygiene issue than anything else with a lot of these daycare illnesses. All right, they don't tend to be kissing disorders or anything like that. These tend to be a lot of things like somebody coughed on something and I've put my hand on it and then I ate something. All right, those are the kinds of things that we're looking at. We're looking at toddlers, things that they eat, right? They eat dirt, they get worms. Those are the kinds of things that we worry about with toddlers. Preschoolers, when we get into preschoolers, remember that this is the fun paint age. This is when we like them again, all right? They're fun, they're friendly, they're always getting into things. Growth is still slow, but it continues, all right? We start getting a little bit more pounds, we start growing a couple of inches. These guys are getting coordination. So all those fine and gross motor skills, they can now start to coordinate some of those muscles and start doing something that's more complex with their feet. But again, not the masters, all right? They're still a little jumpy, they're a little bit uncoordinated sometimes. Takes a couple practice times to get something right. They're the kings and queens of why. Everything is why, how come? Why can't I do this? Why can't I do that? How come? How come? How come? How come? How come? All right, everything's all about this extra energy that they have to get out. All right, these guys have a lot of energy. They need a lot of activities throughout the day. All right, when they misbehave, they're going to be the ones that are guilty. They're going to take it out on themselves. All right, things that are going to happen though, that if they become stressed out, either by that guilt or about things going on in their psychosocial area, these guys are going to have regressive skills. They're going to go back to what made them feel safe as an infant or as a toddler. So things like bedwetting and thumb sucking, those are all signs that there's some kind of stress going on with the preschooler, right? That there's some kind of psychosocial issue. They're not able to process what's going on, all right? But these guys are starting to have this cause and effect relationships. They're understanding that if I hit Timmy, Timmy's not going to want to play with me. Right? So they're having that understanding of what it is that engaging with other people and what it means to engage. Get to our school age kids, we're talking again about this slow, consistent growth. All right, remember that we get to that big growth spurt in adolescence. All right, and that big, big improvement in muscle coordination. Now we've really got a whole bunch of fine motor coordination. Now that we can maybe move and shake our body, we now have this ability to sit down and focus and do our schoolwork, right? Sitting down and doing homework and things like that. We've run out of this thing where it's like organized chaos running around the playground to now I have a strategic way I want to carry out things. This is things like playing school and stuff like that. A lot of reliving those prior relationships, those relationships with other people is a big part of those school age children, right? This is part of that understanding and processing of what's going on in the world and around them, right? So body images, our body's not starting to change, really identifying as a boy or a girl, right? Really finding that collectiveness, that you're with another group, that you're not alone in the world, that you're together, that you're part of that team. A lot of their stress from school age children comes from this idea of not being able to identify as a boy or a girl, finding a group of people that you fit in with that have the same interests and same activities as you. That's where a lot of stress comes in with our school age children, is not finding your group or your gang that you can hang with. Get to our adolescence, again, those physical changes have to do with puberty. A lot of it has to do with this really, really rapid increase in growth in skeleton and muscle, right? And that massive maturation of the reproductive system. Remember that it takes, your body is so much more physically prepared than they are mentally for all the changes that are taking place. It's a very, very slow cognitive process, but it's a very, very rapid physical development. All right, so that idea that we need to make sure that we're kind of letting that cognitive idea body catch up a little bit, right? That cognitive world isn't quite there, even though they look like a 20, 30-year-old girl. All right, so a mother bringing her child in for a regular checkup. The mother reminds the nurse that the child is hearing impaired. Which is the best way to proceed? What do you guys think is therapeutic or the most therapeutic?
See?
See, we don't have an age group on this child. And that's really important, is that we don't have an age group. All right, so we have to assume that this child is able to communicate. And how do we know if they can communicate if we don't assess them first? All right, so the same idea of including that trust and including this kid in the plan of care. All right, very important is B, that excludes the child. We don't exclude the child. All right, we try to involve the child as much as developmentally appropriate. All right, C is very inclusive, and A and D, those are not therapeutic. It doesn't matter how old you are. All right, those are not therapeutic. All right, that has nothing to do with that idea of whether this is appropriate for that age group or not. Those are just not straight up not therapeutic. So in the end, you can eliminate A and D by the fact alone that they just sound rude. Right. So a nurse is assessing a 2-week-old baby at a regular checkup. Which of the following statements by the parent would the nurse determine to be concerning for an endocrine disorder? This was on a recent test yesterday, and I picked this out because I wanted you guys to see the process that goes into this. Now, looking at this question, I want you to say, okay, which one of these needs follow-up? All right, skin is very dry no matter how much lotion I put on. Do I need to follow up on that? You got some questions?
Yes.
Yeah.
Yeah. Why is this kid's skin so dry? Right? It shouldn't be dry. Kid was sitting in water for 9 months. Why is this kid's skin so dry? She eats all the formula I offer at each feeding. Sounds good, right? Sounds like a nice, healthy 2-week-old kid. It should eat. Does not cry and sleeps for 14 hours straight every night. Why is her 2-week-old baby not sleeping? Was sleeping through the night and not crying? Right?
Yes, that one.
Yeah. What's wrong there? Something's not quite right. What about pooping regularly, 2 to 3 times a day?
That's good.
Yeah,
That's good. That sounds pretty healthy. All right. She's able to lift her head up without assistance. That sounds healthy too, doesn't it?
Yeah.
Yeah, that sounds like something this kid should be doing, right? At 2 weeks old. What about this last one? I feel she is smaller than when she was born.
That's concerning.
That's good.
That's concerning because remember that even though they drop weight by 10% in the beginning, by the time they hit 2 weeks, this kid should have started to gain, right? These kids are supposed to grow fast. And so if this kid's not growing and I'm kind of going, she's smaller, let's stick it on a scale and find out, right? So even though it's not something that I'm going to ask her about, it's something I'm going to stick this kid on a scale and see where this kid is, right? So that's the big idea behind there is you want to see what kind of things, look at those, what are expected and not expected. And that's where you use that secondary prevention knowledge, is that saying, okay, is this expected? And the big key here was that this kid was 2 weeks old. We have to keep that in mind, right? We have to keep that age group so much in mind. And that idea of which one's follow-up assessment, which one do we need to actually weigh this baby for, or ask a couple more questions like, what kind of lotion are you using? All right. Or tell me more about that sleeping for 14 hours straight. What do you mean by that? Like, tell me more. Give me some more information about that. All right. So anything you need more information on is something that you should be like, that's concerning. Because this really wasn't even about there being an endocrine disorder. It should be what's not right for a 2-week-old baby. So tertiary prevention. How do we get them better? So now that we've got a kid that's got something wrong, there's something wrong with this kid. We've got to figure out what it is. Now, a lot of times we have 2 options. It's either acute and it's something that's going to resolve or something that may happen again, or a chronic disease, which is something that we've got to monitor for and monitor their compliance. And we have to do autonomy. How much can they do by themselves, right? If we've got an acute disease, we have to figure out first, is it contagious? Can I, the nurse, catch it? Or can everyone else in their family catch it? Or everyone at schools catch it? Does this acute disease cause immunity? Does this mean that this is the only time that you'll ever have this disease and you'll never get it again? Or is it something that can happen over and over and over again? Because if it has a risk for recurrence, then we have to talk about prevention strategies, especially at discharge. All right, especially at discharge, we have to figure out why this happened, first of all, and then how we can keep it from happening again. All right. This other idea too, when we're dealing with tertiary prevention and how do we get them better, is this kid able to make a full recovery, or am I planning for end of life care? Is this a situation that I've got to say, okay, I've got to make sure that the family knows that we've got to plan for the rest of their lives now, that this is not something that they're going to get over. All right. So acute diseases, as far as they go, the most common ones in kids are respiratory and GI. All right, the primary ones for the kids. All right, and so what happens is respiratory, we always have to think about this idea of isolation. Is it droplet or is it airborne? So really important to remember which ones we got to stick them in airborne for and which ones have droplet. And if we don't know which one it is, do we put them in airborne first and then wait? Or do we put them in droplets and wait? All right. The other thing to remember too, when we're talking about that isolation, is that remember this idea of antibiotics, that if we get 24 hours of antibiotics, they're no longer contagious. All right. But it has to be bacterial. It may be something that's viral with respiratory. So figuring out which ones are viral and which ones are bacterial is very important. Who can we plan for antibiotics for? All right. Prioritize airway, always with that respiratory system, always making sure that we know where the problem is. Is it upper respiratory that we need a tracheostomy if they start not being able to breathe or they start turning blue? Or is it lower respiratory that they need oxygen? Do they need bronchodilators? All right. Do they need a nasal cannula or face mask? Do we need BiPAP for this kid? All right. Those are the kinds of things that we'd use for a respiratory, for a lower respiratory infection. For upper respiratory, you can put all the oxygen you want on this kid, or you can put all the bronchodilators you want on this kid. It's not going to fix the problem. The problem is up top. There's a noose around their neck. Something's happening. All right. And remember, if any condition has mucus, you always want to increase hydration, make sure you have suction, and position them for lung expansion. Those are all things that are going to be therapeutic management for all those conditions. So knowing which ones have mucus and are mucus creating conditions, which ones don't have mucus, right? That's all part of those respiratory disorders. GI disorders, we're always going to look at things that whether they have contact precautions, because GI disorders don't come in droplet or airborne. So now it's whether do I put them in contact precautions or not? Can they be hand washing or hand sanitizer? Remember that idea of C. diff, all right? And the same idea too, is this a surgical correction for this GI disorder or a non-surgical? Is this something that's going to pass and stop on its own? Or is this something that has to be corrected? Is something congenital? Is it something they're born with? And if it's something they're born with, is it something that they can live with or is it something they will die from, all right? Does it alter the function and make it so this kid won't survive, won't have that will lead to that organic cause of failure to thrive. All right, same thing too, if we're doing anything with gastrointestinal, we're always getting I's and O's. Always, always, always paying attention to those I's and O's and figuring out if it's a gastrointestinal disorder, where are we losing? Are we losing from the top or are we losing from the bottom? Are we looking for an acidotic syndrome? Or are we looking for an alkalotic syndrome? All right, is this a syndrome characterized by a lot of diarrhea? Or are we characterized by a lot of vomiting? And that's going to help guide our plan of care because we're going to do things differently based upon whether it's an acid or not an acid. Right? Chronic diseases fall into two areas that we really have to be concerned about. We have to worry about susceptibility and vulnerability. Are these kids at risk for infection or injury? Is being out in the world going to cause problems for this child? So if we have metabolism disorders, we have this risk for diabetes, right? So diabetes, we're giving that management. We have to keep this idea in mind that diabetes, if they get injured, if they get an infection, it changes the treatment plan, right? If they get an acute respiratory infection, any kind of infection, again, we have that risk for DKA. We have that risk for problems related to that, right? If they're hematological disorders, like sickle cell or any of our hemophilias or bleeding disorders, we again have that risk for injury. This is going to be a problematic area, right? If we have diabetes and we get an injury, well, when we have diabetes and injury, we might have that slower healing time, and that's something we have to worry about. And does this chronic disease restrict participation in activities or social groups? These are things to think about with your respiratory or cardiovascular oncology. Do these interfere with their ability to meet those psychosocial milestones, right? Does this interfere? Remember, this is about chronic disease management. So a lot of chronic disease care for respiratory, cardiovascular, and oncology disorders is all about getting these kids to maximize their ability to be in activities and to be in social groups. So the questions that come with the treatment of these disorders has a lot to do with how do I get this kid involved in activities or social groups? How can I make them so they can be around people? How do I make them so they can participate? All right, because it's not going to be how do I manage this chronic disease to keep them in the hospital? No, it's going to be how can I get them out and into the activities? Because remember, these chronic diseases don't go away. All right, so there's something we have to learn to live with. All right, so how do we plan for letting this child live their life? All right, remember that if you have a chronic disease, it makes it harder to fight an acute disease, especially if they're in the same system. So big plan on prevention here is about preventing things So if we've got a respiratory disorder and we've got a chronic respiratory disorder, we're going to do everything in our power to prevent acute respiratory disorders from happening. All right, because that we need to do things like vaccines and hygiene and safety to make sure that those things are controlled. All right, so a nurse is assessing an 8-week-old infant with heart failure on digoxin. Which would be appropriate clinical manifestations of digoxin toxicity? This question should look familiar. Which one is an appropriate manifestation?
Visual disturbances.
Right? So the problem is here is that this idea that we want this vomiting, bradycardia, or feeding, because those visual disturbances we can't assess on our 8-week-old infant. We can't do it. Even though it's a symptom of that digoxin toxicity, we can't see it. And I know that this is something that came up on one of our exams. Is that halo and blurred vision? We can't assess that. We can't ask an 8-week-old infant, are the lights blurry when you look at them? All right, think about those age groups. All right, so keeping those age groups in mind, that age group is not there for decoration. It's there because it means something in the question oftentimes, especially in pediatrics. They don't go through the time of thinking about what age they're going to make the kid for the question if it doesn't mean something.
Thank you, Professor. And you know what? I want to say this for my classmates. Sometimes I don't read the whole question, and that's the big no-no. Especially like when you're getting behind. I don't know if this happened to anybody else, but sometimes when you're getting like behind the time in the test, and that you prefer to answer all the questions than, you know what I mean? Sometimes I don't read the whole question. And then you see, I just did it with the digoxin toxicity, but it's 8 weeks old. How is going to tell me I cannot see correctly? You know what I mean? Thank you for explaining that.
Because it's about your gut reaction leads you towards it. Now, I wanted to show you guys this question too, because this was a question that a lot of people struggled with. All right, and really important to match those drugs with the purpose they serve, because this has to go into education too. So what are those LABAs for? What are the long-acting beta agonists for?
Prevention of exacerbation.
Yeah, they're going to prevent, right? They're not good for short term. What about the short-acting, the SABAs? What are they good for?
Emergency situations.
Yeah, it's about that reversal, right? Reversal of acute bronchoconstriction. So not chronic anything, that acute. Put that short-acting, that AC, with that AC. And the corticosteroids, what are they for?
Inflammation.
Yeah, and this is what you should be doing with all the drugs that have multiple medications. So if you've got a disorder that has multiple medications, like your cystic fibrosis, like your cardiac patients, right? Your CHF, your congestive heart failure patients, seriously, write down and make a list and say, okay, this patient's on furosemide for this reason. This patient's on a beta blocker for this reason. Know what those drugs' purposes are and what those are for. And that's going to help you guide what you're going to do, because you have to have that kind of that matching idea in your brain. So that way, when you're reading all the way through, like Paula was saying, you have to see all the way through, because if you don't read all the way through, and that's how a lot of people missed one of these questions on the test with this, because they didn't read all the way through, that the parent was saying that the SABA was going to do this underlying inflammation. Well, that's not what the SABA does. All right. And the LABA was going to reduce, was going to be for acute bronchoconstriction. The LABAs don't do that. Right. So this idea of reading things kind of all the way through, but kind of making sure that you're eliminating things that just don't make sense. Read it once and say, does that make sense? Because if it makes you start having little questions in your mind, you got to say, that's not quite right. All right. I do want to see like this kind of setup is what I'm talking about. Like when we have this idea of sickle cell disease, how do we manage a crisis? So you've got one little thing on the side, crisis, hydrate, oxygenate, pain management. That's how you manage sickle cell disease. But remember that if you have an acute problem, that acute problem is more lethal than the chronic issue. And always, 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 when you see something that's about an action or taking an action, we're always going to assess first and then take action. But make sure that assessment makes sense, because that assessment sometimes does not make sense. But oftentimes when it's asking you to prioritize something or intervention and you're going to do something first, oftentimes it's asking for assessment. What assessment needs to be done on this patient? All right, the same thing here on the right. I want you to see how this maintenance is kind of set up. And you should do this with a lot of your disorders, because this is going to give you like a flip page, right? So you can kind of glance at it and say, okay, this is my sickle cell page. And so I can look at it and go, okay. And so if I see a question in my mind, I'm going to close my eyes and say, okay, let me see my sickle cell page in my mind. This is where everything is. And sometimes you may not be able to see the words, but you have that feeling, that understanding, right? So maintenance part of sickle cell disease is all about medications to reduce anemia, iron and folic acid, medications to control chronic pain, PO and long-acting morphine and oxycodone, all right? Blood transfusions, that's part of that care. So linking that whole idea of blood transfusions and everything that goes with that, how to transfuse blood, what things to worry about, things about how reactions, right? Antibodies and things like that should all link into this sickle cell, right? Bone marrow transplant as being a last resort treatment. Again, it's not done very often because it's such a chronic illness. The risk is very, very high, all right? And we have to consider too that best IV access for that patient is going to be a port, because this is going to be a patient we see over and over and over again. Unlike our asthmatic patients, where none of our pet meds are given through IV. All right, most of our meds for asthmatic patients are given through inhalation. They wouldn't be somebody we'd want to port on, but we might want an IV if they've had antibiotics and they've got an acute respiratory disorder. So really think about this idea of what kind of IV access would be appropriate for this kind of patient. What would be your first guess that you would think this patient has, right? And then this idea of education is really about prevention of a crisis, right? So this is, I wanted to show you this as a neat example of kind of how to organize each disease process and go, aha, this is sickle cell disease. And this is in a nutshell. So a lot of your questions that have to do with sickle cell disease are going to play off of some kind of either crisis or management situation. And it's going to be, what's the priority here, right? Or what's the long-term care? What's that long-term treatment? All right. When we're talking about recovery versus end of life care, which is really something we're going to get into next week, but I want to make sure you guys have some kind of knowledge going into this, that really we're going to focus on age appropriate responses to death and dying, whether it's their own death or somebody that they know dying. Because a lot of times that people don't have that idea of, okay, somebody else is dying, and that grief response, especially if they're very little and as they enter a new developmental stage, they have to reprocess that death with a new developmental understanding of that death. So somebody who has somebody die when they're a preschooler is going to reprocess that death when we get to that early age of elementary school. They're going to reprocess it again as a senior. They're going to reprocess it again as an adult. They're going to keep reprocessing that death because they haven't processed it with that awareness of the world, right? To that idea of that reprocessing of death, as well as their own approach to death. All right, it can be very, very matter of fact when we're thinking about little ones. They just think about this, oh, I'm gonna die. And they just kind of go on with that like that. But when you get into these other areas where they start thinking about other people, that's when we get into this idea that they start having more deeper thoughts into death and wanting to make amends with other people, right? And really about this decision-making capacity. What decisions can they make? What things can we focus on for them to do? All right, I think we got this last question. So a nurse is caring for an adolescent with a nasogastric tube feeding. Which assessment findings would be the most concerning? Think about this idea of concerning. Where does this concern come in? Think about this idea of these feedings, and this food is coming in, constantly coming in.
Decrease bowel sounds?
Yeah, because we need the body to be processing. If we don't have the body processing, well, then we don't have that feeding going anywhere. It's just building and building and building in this stomach. All right, distended abdomen can sometimes be expected when we're dealing with this stuff. All right, it's abnormal, but it's not the most abnormal it could be. All right, there just may be a lot of gas in there. B means that the bowel's working, the food's going away. C, this idea that this dry mucous membranes, right, they might need more hydration or an oral care or something like that. Something's missing. They might need some more free water or something in their lives. All right, but that decreased bowel sound is that need for follow-up assessment. All right, and the way that this builds into this whole idea is that if this kid is going to be a chronic nasogastric tube feeding or an acute nasogastric tube feeding, all right, what do we expect it to be? What do we expect to process from this child, right? Because either way, if they're chronic or acute, the decreased bowel sounds are the biggest problem, because it shows us, hey, that maybe this food isn't processing. Maybe there's an absorption issue, right? So that's a big sign that we need to follow up. We need to find more information on. All right, our second best answer would have been that distended abdomen. But again, this can sometimes be normal depending on what condition has led them to needing this bowel sounds. All right, my friends, we have a couple minutes for questions if anybody has them, but that's kind of what I got for you.
Going back to that last question, Professor, why wouldn't dry mucous membrane be alarming if that was a symptom?
Remember, it was about the most concerning,
Mhm.
right? So that idea about being the most concerning. So what's the
Okay.
worst that could happen, right? And the worst that can happen is this kid can aspirate food.
Got you. Okay.
Got it? So it's about that aspiration risk. And that's where the bigger problem comes in, is that this kid could be aspirating that food. So think about the worst that could happen. So the worst that could happen with dry mucous membrane is, they're a little thirsty, right? Somebody didn't wash their teeth today or something.
Okay.
Anybody else got anything?
Thank you, Professor. Thank you. I'm going to watch the video later, the recording.
Yes.
And then start creating sheets. I'm going to try that because I'm visual. Sometimes when I take a test, I can imagine, like you said. That was funny. I was laughing on that because that's what I do. And I can see in my sheet, the sheet in my brain, like you said, in my memory. I cannot see the words, but I can remember. I can remember the way I laid it out and everything, and that helped me a lot. I did that in fundamentals too. I mean, every class I try something different, but let's see. I'm going to do that. That helped me a lot. And also, it helped me when I take notes by my own. Like follow the PowerPoints is nice, do the outlines is nice, but I had to make like a flashcards, but write it myself. That helped me. I don't know. And then I reviewing. You're reading what you're going to write in your flashcard. That's 2 times already you're reading. And then when you review again, I think in this class we need a lot of no memorization, but repeat and repeat and repeat so you can get.
It's a lot of repetition. It's a lot of repetition. It is. It's hard.
So thank you so much. I know it's hard, but I know we can do it.
I think you all can do it. I think you all have the capacity to do it. It's just a matter of doing it. It is. It's tough.
Do you have any other recommendations to help us study for the CMS?
Really, the big thing is look at differences, right? Really, really, really look at differences between things, because that's what they love to bring up, right? So things that are very close in disorders, right? The differences between, croup and maybe like bronchiolitis, like those are the kinds of things that they're going to bring up, right? So they really, really like differences. And a lot of that early developmental, that psychosocial for each age group is something that they come up with quite a bit.
Okay, thank you.
You're welcome.
Any supplements for the brain or that you can recommend? I just kidding.
Yeah, I wish. But what I'll do is
nice,
I'll
Professor. Like to make up.
Yeah, just a little something to get you guys to think about the things you need to do for this CMS exam. But honestly, I'll put some links into some PEDS reviews into this week's announcement for the week on Sunday morning that are kind of like general PEDS reviews that might be helpful just to kind of put on and listen to and kind of hear things again from somebody else, because I think it helps. Again, that idea of repetition, just hearing it over and over and over again, it does help.
Professor, do you think, now that we had this time with you, what do you think about the ATI book? Because in my previous classes, I used the ATI book a lot, and it really helped me a lot. Like I really never read my textbook, right? But in this class, I couldn't follow the ATI. Now I like to review the questions and the ATI at the end of each chapter. What do you think about the Saunders?
I like the Saunders book. The Saunders book is very good. I do like the ATI book though. The ATI book I think is very good. It's just the problem that it jumps around a lot. And that's why I started putting it in the weekly announcements, which sections in ATI to read, because it really does kind of follow a different plan than the actual textbook for the course. And that makes it hard to see both sides, I think.
I also review. I'm going to review the NCLEX book from the ATI, the ATI NCLEX. I was looking at and some questions about topics that we. So I'm going to like pick a little bit of every. I think what we need is time, the time, and I think we will do good. So it's going to be a long weekend. And
Yes.
thank you, Professor. I got
You're
to go, but
welcome.
thank you so much for this. And we're going to have the recording, right? That's important.
Yes, I'm gonna put it on YouTube and then I'll put it in class for you guys, so you'll have it.
Okay. Thank you so much.
You're
Have a nice
welcome.
weekend.
Thanks, Professor.
You're welcome. Have a good
Thank you.
weekend, guys.
Thank you.
You're welcome.
Goodbye.
Bye.
Bye.